This is Chapter 39, Pediatric Variations of Nursing Interventions for NUR 203. You have 13 objectives for this chapter, and y'all can read those and follow along at your will. General concepts related to pediatric procedures. Informed consent. The person must be capable of giving consent. That is usually age of majority, age 18. Person must receive the information needed to make an intelligent, informed decision, and the person must act voluntarily when exercising freedom of choice. Each state has its own laws about emancipation. Usually it involves going to court and being able to prove to a judge that you can support yourself without help, or that you are a mother with children under the age of 18 or married. And all 50 states have enacted legislation that entitles adolescents to consent to treatment without a parent's knowledge to one or more medically emancipated conditions, such as sexually transmitted infections, mental health services, alcohol and drug dependence, pregnancy and contraceptive devices. Legally, children are not able to give true informed consent until they turn 18. So before taking part in a clinical trial, they are asked to give their assent, which means that they agree to take part in clinical trials. They may also dissent, which means they do not agree. You can look those laws up at your will for whatever state you're interested in looking them up for. Different in every state. Legally, children are not able to give true informed consent until they turn 18, so before taking part in a clinical trial, they're asked for their assent. Assent means that they agree to take part in a clinical trial. They may also dissent, which means they do not agree to partake. So, can I seek emancipation? Is a question that a lot of teenagers look into. They divorce their parents, they get emancipated, whatnot. Glad I'm not raising children anymore. Minors who are at least 16 years of age are eligible. Minors under the age of 16 or minors not able to provide sufficient evidence that they are able to care for themselves and provide sufficient evidence to the courts to support themselves are not eligible. And this slide tells you about Florida emancipation and the laws pertaining to that. I'm not going to read that to you. You're perfectly capable of reading that for yourself. Our goal as pediatric nurses is to prevent separation and anxiety for our patients. The most effective preparation includes the provision of sensory procedural information and helping the child to develop coping skills such as imagery, distraction, or relaxation. See the guidelines on page 1069 for preparing children for procedures. This information goes into age-specific points to remember. One of the key things, as you can see on this slide, tells you that we need to allow them to express their feelings. That's very important. So preparation for diagnostic and therapeutic procedures is on that same page. Physical preparation, performance of the procedure, we need to expect success, involve the child, provide distraction, and allow expression of feelings. Post-procedural support, encourage expression of feelings, big on the expression of feelings, and positive reinforcement. Performance of the procedure, playing with medical objects provides children with an opportunity to play without fears and concerns with supervision by a nurse or child life specialist. General concepts related to pediatric procedures are listed here. Surgical procedures, preoperative care, and postoperative care. Parents being present is usually the very most important thing, and having their transitional object with them, whether it be their favorite blanket, their pacifier, their favorite stuffed toy, a little He-Man or whatever, you know. Oh, that's old. Oh, that's old school. I dated myself with that one. Iron Man or Batman or some kind of little toy for boys that they're a dinosaur or whatever that they're fond of that gives them comfort is their transitional object. Keeping pain under control will be the key to cooperation for any patient. And children do not complain as a general rule. If they are distracted and happy, they forget about the pain, unlike adults. Parental presence during induction of anesthesia can minimize the child's anxiety during the preoperative period, where this mom looks perfectly content and happy. The child, not so much. I don't think mama being present is helping her one little bit. So then compliance, clinical judgment, self-reporting, direct observation, these are all concepts related to pediatric procedures. Monitoring appointments, monitoring therapeutic response, pill counts, chemical assay, and compliance strategies. Skin care and hygiene, even with children, we need to make sure that they're healthy, their skin is healthy. If they're unable to get up and move around like they normally do, if they can't get up and take a shower or bath for themselves, we have to do bed baths, oral hygiene, and hair care for them. Feeding the sick child whenever we need to, that's what we do. Whether it's an NG tube or an OG tube or whatever feeding is appropriate for that patient. And we allow the mother to do the feeding whenever she's present, because I'm sure the child would rather his mother feed him than a nurse. Therapeutic management of fever and hyperthermia, and family teaching and home care. You can read more about it in your chapters. There's a difference between fever and hyperthermia, and I put this slide on here because I need you to understand the difference. In fever, it's also known as hyperpyrexia. Fever is an elevation in set points, such as a body temperature regulated at a higher level. It may be arbitrarily defined as a temperature above 38 degrees centigrade or 100.4 degrees Fahrenheit. Fever is usually treated with an antipyretic, such as Tylenol and NSAID or aspirin in certain diseases. Fever is also treated environmentally by putting on less clothing, a tepid bath, which is just warm water, not cold water or hot water, or a combination of both. With hyperthermia, it's when the body temperature exceeds the set point such that the body or external conditions create more heat than the body can eliminate, such as in heat stroke, aspirin toxicity, seizures, or hyperthyroidism. Unlike fever, antipyretics are of no value in hyperthermia because the set point is already normal. Commercial cooling devices like cooling blankets or mattresses are available to help in the case of hyperthermia. Safety is always something we need to be careful about with our patients, no matter what age they are, but particularly with pediatrics. We need to make sure that the environmental factors are safe, like the electrical equipment, the furniture. We worry about strangulation. Children can get into some awkward positions, twisting and turning around in that bed, rolling around, writhing, screaming for their mama. You have to worry about them even getting tangled up in their IV tubing. Toys need to be appropriate for the aged child, and always make sure that side rail is up so they don't fall out of that bed. Infection control, role of Centers for Disease Control and Prevention. Is always important that we report certain things to the CDC when it comes to children and their childhood diseases. Standard precautions should be used with every patient. Transmission-based precautions should be passed on in your SBAR or your report from nurse to nurse so that nothing gets missed and overlooked. And you know we all have some patients who will be on airborne, droplet, or contact precautions. Transporting children. Infants and small children can be carried for very short distances, but in most hospitals they require you to transport them in something else other than your arm, like a bassinet or crib, a stroller, a wagon, a wheelchair, stretcher. We often had children around on the unit in wagons at the nurse's station when I was working peds. Restraining methods. Alternative methods consider first diversional activities, parental participation, therapeutic holding. Use the least restrictive type of restraining method, and behavioral restraints can be used when significant risk is present, and determine the cause of the behavior first. There's a mummy restraint, or commonly known in very small infants as the swaddling. There's a jacket restraint, like a straitjacket. There's an arm and leg restraint, and there's an elbow restraint. Controlling the child for procedures. Parents being present is usually very important, and having a transitional object of importance to the child can be equally important. Keeping pain under control will be the key to cooperation for any patient, and children do not usually complain. As a general rule, distraction works with them. This is your swaddling on the left, or mummy restraint as they call it. The one at the top right is your wrist restraint, and the one at the bottom is your elbow restraints. Those are just velcroed around the arm to keep the child from being able to reach their face. They can't bend their elbows with those on. Positioning for procedures, your femoral venipuncture, we do what's called the frog leg procedure, where we just spread their legs and put their feet together so they're in like a frog leg position. Extremity venipuncture, or injection, depending on whether you're a one-person team or a two-person team and how big the child is. It is possible to hold down a child by yourself to do what you need to do by throwing our body over them in order to get a good grip on them. Lumbar puncture, they're usually folded in two so that the back is exposed, and we have to hold pressure to keep their arms and legs from moving during the procedure, which can be very taxing on you, and you don't know how long it's going to take, so you need to have a person to spell you out in some cases. Bone marrow aspiration or biopsy, we'll talk about in a minute. Collection of specimens, fundamental steps common to all procedures. The urine bag for collection of urine, clean catch specimens, 24-hour urine collection. Bladder catheterization and other techniques are all in your chapter reading. Stool specimens are usually collected from the diapers of smaller children, and we use the hat for collection for the older children. Just set it in the toilet and have them poop in that. Blood specimens depends on how much blood they're ordering, whether we do a heel stick or venipuncture. And respiratory secretions are usually collected by respiratory therapy, but we can do it on the nursing unit just using the regular suction with a D-Lee suction apparatus for collection in the middle. This is where we do the heel sticks on the left or right of the bottom of the foot, not in the middle because of the nerves that run down the middle of the foot. Administration of medications. There's few standardized dose ranges. Body surface area, most widely used in oncology. Usually we use milligram per kilogram per day. Checking the dosage is very important, but in most hospital inpatient facilities, the doses are calculated for the child, and they're metered doses for that specific child, and they're sent up from the pharmacy. Or in the NICU's case, they have their own pediatric pharmacist that's right there on the unit, and he or she prepares all the medications for the children right there in the unit. So we no longer have to figure out what needs to go in the dose and pull it up ourselves. That's usually not an issue anymore. Gentle restraint of a toddler for administration of oral medication in a syringe works when they cooperate, but guard yourself against the one who will spit it right back in your face and all over your uniform. So it happens. Oral administration, preparation and administration, we already talked about. IM injection, selecting the right syringe and needle, and determining the site and administration is all in your chapter reading. This is a great position for holding a child for an injection when you're working alone and doing a vastus lateralis injection in the thigh. Subcutaneous and intradermal administration also in your reading. IV administration, where we place the line, peripheral intermittent infusion device, or an INT as we call it, central venous access, and implanted infusion ports. Those are usually our chemotherapy and long-term illness type patients. And an interosseous infusion is into usually the tibial bone in the leg when there is absolutely no other access to be found. And this shows your external central venous catheter insertion and exit. The child with external central venous catheter, the child with an implanted port and a Huber needle that's inserted without a dressing on at this time. There's a side view of an implanted port with the Huber needle inserted. And from the previous slide, that's the external central venous catheter insertion and exit. I said that already. Read the nursing alerts on pages 1102 and 1104. Maintaining fluid balance, measure of intake and output, fluids to be measured. Nursing responsibility to identify when fluids should be measured. When weighing a diaper for doing eyes and nose for infants that are on strict eyes and nose, you have to weigh the diaper dry and write the gram weight on the diaper. And then when it's wet, then you re-weigh it and subtract that dry weight from the wet weight to get your milliliters of urine. This is the only time in any field where there's a dry weight that converts to a wet weight. So it's a 1-to-1 conversion. If your diaper weighs 10 grams dry, and when you weigh it after the baby urinates and it's 15 grams, then your milliliters of output was 5 milliliters. Just subtracting the difference. There was a board's question once that one of my students told me about, where you had to weigh a diaper and give them the correct conversion. Special needs when the child is not permitted to take fluids by mouth. NPO, usually they're on IV fluids, or if it's long term because of say a bowel reduction or something, then they may be on TPN and lipids. Which, by the way, is the next slide. Parenteral fluid therapy, site and equipment, safety catheters and needleless systems, infusion pump, securement of the peripheral IV catheter, removal of peripheral IV lines, maintenance and complications. Teach the parents how to do the one-person hold to administer if needed. See page 1109 in the nursing alert box. That's for rectal administration of meds. When you have a child that's on TPN and lipids, the lipids are the white solution, it's the fats that come in a separate bag, but the TPN has a very high concentration of glucose. When it's more than 12% or more than 10%, they really should use a central line or a PICC line, not a peripheral line for that, because if that line infiltrates, that glucose will literally burn a hole through the child's vein and into the skin and leave a really nasty wound that sometimes needs to have skin grafts done to it. It's that bad. So we really have to be very careful about that. So preferred sites for venous access in infants. The scalp veins are often used for infants, but can be hard to secure. If you have to shave hair or clip hair, that's considered their first haircut, and most parents get upset about that. But if you save it on a piece of tape so they can keep it in their baby book or keep it as a keepsake, that sometimes helps, but we try not to have to do that in most cases. Foot veins should be avoided in children walking or learning to walk, and restrict movement as little as possible. This is a transilluminator where they're using a special light to see a vein, and you can use sometimes a pen light or a flashlight will work just as well in a dimly lit room. This is pictures of the needleless systems that you might see at different hospitals that you're going to work at. And this is a StatLock securement device, very expensive, but it's wonderful, it's great, it's beautiful, but you're not going to see it anywhere around Jacksonville. This is also very expensive. It's an IV housing system used to protect the site. It's also very expensive, and like I said, in all my years in Jacksonville working as a pediatric and NICU nurse, I never saw either one of these. Rectal administration of medications, alternative routes when oral route is difficult, or if the child is vomiting and can't hold anything down, you may have to do the rectal thing. So the technique is to insert beyond both rectal sphincters and hold it tightly for a minute or two so that it dissolves before you release the buttocks. Eye drops and ointments techniques may be difficult to obtain cooperation from the child. School-age children cooperate better with these things. And infection control concerns, we need to be very careful that the eye drops don't roll from one eye into the other, because they may have an infection in one eye that we don't want to get into the other, so we need to be very careful about that. And here is a picture of how she is careful not to touch the dropper to the eyelid or the eyelashes, because that also contaminates it. And nobody likes to have nose drops put in their nose. Aerosol therapy deposits medication directly into the airways, useful in avoiding systemic side effects. It's usually nebulized with oxygen, and they can use metered dose inhalers and spacers to get the proper amount of dosage into these children. Advantages of nasogastric, orogastric, and gastrostomy administration is the ability to administer medications around the clock without disturbing the child. The disadvantages are occlusion. They clog up if people don't flush them adequately in between medications, or they try to give more than one med at the time through the tube, because the outlet into the stomach is not that big, and chunks get in there and clog it up. You can see the guidelines box on page 1111. Alternative feedings would be your gavage feedings. Preparations and procedure would be usually by gravity. Sometimes we would run feedings over a pump, one of the little syringe pumps for a small child. Might run 20 to 30 minutes of time, because gravity feedings would not go in. The tubes that they use in children and infants are very, very, very tiny, like a 5 French size. So going in by gravity might take a good long time, because some of these babies were being fed thickened formula and whatnot, so you'd have to push it in over a pump. Gastrostomy feedings are a bigger tube, so they usually go in well by gravity. The nasoduodenal and nasojejunal tubes go into the small intestines, and those tubes have a weight on the end of them, so they're actually weighted to stay down below the stomach. The doctor puts those in under fluoroscopy. We cannot put down those tubes. And then there's TPN and lipids we already talked about. This is measuring the tube for an orogastric feeding from the tip of the nose to the earlobe and to the midpoint between the end of the xiphoid process and the umbilicus, and then we insert the tube. Some of these tubes are marked already at little small increments with little black lines, but if they're not, you can mark it with a piece of tape, or you can make an ink mark on it with your ink pen so that you don't go beyond that point. Skin level devices, that would be your Mickey tubes, total parental nutrition, TPN. For infants, the dextrose in TPN is usually 12.5, so that needs to be in a PICC line or a central line. This is the appearance of healthy granulation tissue around the stoma, where this child has a G-tube inserted. And this is your Mickey tube, child with skin level gastrostomy device. The Mickey, which provides for secured attachment of extension tubing to the gastrostomy opening, and it clamps off. They get slimy from opening and closing. Sometimes you have to make sure you keep them clean so they stay closed, or you can get some leakage back from that. Enemas, not recommended. Techniques, age, weight appropriate. You can read all that in your book. Ostomies, skin stoma care, and techniques and purpose are, it's an art to be able to do an ostomy. And ostomy care on an adult patient, much less on an infant or a child. It's real. I've never been artsy craftsy, so I was never really good at this. So we always had a skin care specialist who would come and do our ostomies for our NICU babies. The procedure for maintaining respiratory function, inhalation therapy, the oxyhood, nasal cannula with prongs. Newborn infants, especially premature infants, can be on ventilators for a very long time sometimes. In that case, if they're micropreemies, 24 weeks to 32 weeks, they can sometimes get what's called retinopathy of prematurity, where the retina starts to try to detach because of over-oxygenation, being on high doses and concentrations of oxygen. So they will do an ROP exam on those children when they're about 32 weeks. The ophthalmologist will come in and look to make sure that their retina is not detaching, which means they could end up blind from too much oxygen concentration. This is a baby on an oxyhood. And of course, this is an oxy sensor on a baby's not so big toe, the big fat foot. Procedures for respiratory function intubation, usually the physician or the respiratory therapist will intubate, and they'll have the ventilator set up when a micropreemie or a preemie that's in respiratory distress is born, and come to the unit and be ready to intubate them if they don't have to already do it in the labor and delivery area. Tracheostomy, suctioning, routine care, emergency care, tube occlusion, and accidental decannulation. And chest tube procedures you can read about in your book. This is the Celastic Pediatric Tracheostomy Tube and Obturator. And this shows how to do suctioning. On page 1121, please read the nursing alert boxes. One finger should be able to get between the tie on the neck that holds the trach in place. And this is your Pleurovac drainage systems for chest tube drainage, and a schematic of the drainage system on the right. The preferred site for intramuscular injections in infants is, I'm not even going to pretend like you don't know the answer to this. You know that it's vastus lateralis. And this concludes this chapter. Thank you.